Overall, the goal of ECTRIMS is to improve life of patients that are affected by demyelinating inflammatory diseases such as multiple sclerosis. This is natural that patients are included in this journey, and this is why, beside or included now in this Congress, we have developed this Patient Community Day.
Events like Patient Community Day bridge the gap between the research community and patients because of this knowledge transfer that happens between the clinicians/researchers/scientists to the patients/caregivers. This intersection rarely ever happens. There is rarely an opportunity for both of these major stakeholders to come together and talk about this common cause, which is our diseases.
We are all feeling, speaking the same language. We are all feeling being in the same world. It's not from one side the patient, the other side the scientist, and the other side the clinician. We are all with the same goal.
And that's why it's important to get doctors together, to get patients together, all in a room talking about this stuff so that we can all have different health outcomes. Because it's not just a drug, it's not just a diet. It's a whole universe coming together in one patient. And that's really something that you cannot understand until you do it for yourself.
Overall,
good afternoon, everybody, dear ladies, dear gentlemen. A warm welcome to all of you for the 4th annual Patient Community Day. My name is Professor Bruno Stankoff. I'm a neurologist in Paris, France, and also a researcher. And I have the honor to act as the current ECTRIMS president. As you have seen in the video, this is the 4th time we organize this event, and it's becoming an incredibly special and important event for us. Over the past days, the 4 past days, our scientific community have come together and shared and discussed hundreds of presentations, either scientific or clinical presentation, outlining the progress made this year in the field of MS, but also related conditions. Today, we aim to share and discuss some of those highlights directly to you, the people at the heart of this work, those living with MS, with NMOSD, with MOGAD, or other rare neurological conditions. I'm delighted to announce that this year we have reached a record number of registrations for this Patient Community Day, which attests of its success, and it also shows how dedicated the community is to engaging and working with us to accelerate research in this disease. Thank you to everyone who has joined, either here or online. We hope that you will leave today informed and inspired about the progress being made in the understanding of treatment your condition. Lastly, I would like to thank also our sponsors who are supporting partners for their commitments and generosity that deeply contribute to make this event a success. So I will now stop here, and I would like to introduce the co-chair of our local organizing committee and local chair, Professor Xavier Montalban, to say a few words. Thank you, Xavier. Thank you to you.
Thank you very much, Bruno. My name is Xavier Montalban. I am a neurologist working here in Barcelona, and for the last 30 years, I have seen patients with multiple sclerosis. And I would like to start by providing a greeting to our audience in our local language first, and then I will switch back to English. Because I know, can I ask, ¿puedo preguntar cuántos de ustedes hablan español? I'm going to talk from now on in Spanish, right? Bueno, bienvenidos a este acto. Llevamos 3 días y medio hablando de esclerosis múltiple desde todas las perspectivas. El presidente y los miembros del Steering Committee y yo parecemos que estamos cansados porque estamos cansados, pero a la vez estamos muy contentos de teneros aquí con nosotros. Quería dar las gracias específicamente a las asociaciones de pacientes, especialmente a Esclerosis Múltiple España, a la Fundación Esclerosis Múltiple, que han hecho un gran esfuerzo para organizar y contribuir a que este acto sea realmente un éxito. Les ruego que participen, que pregunten, en fin, que sean muy proactivos. Switching back to English for 3 or 4 people here. Now, back to English. Hello and welcome everyone to this beautiful city of Barcelona for the 2025 Patient Community Day. It is truly amazing for me to look out into the room today and see so many people joining us in person, as well as the many people that are watching online. Quite a number of people, I was told. To everyone here today, thank you for recognizing the importance of this event. We know that the work that we do each and every day is better when you are part of it. I hope that you enjoy today and use this opportunity to learn about the exciting research that is happening around the world. But also, this is a unique chance to share your thoughts and ideas with us and to connect with other people in the community, researchers, neurologists, allied health professionals, and supporting partners. We are all stronger when we work together, and that's very clear. And with this, I would like to now introduce Brett Drummond, who will be our host for today's event. Brett, please. Thank you.
Thank you, Javier. I am one of the 3 to 4 people in the room that Javier needs to speak English for. I will not be speaking Spanish to you today. I want to start by having you all just look around the room because from my viewpoint, this is truly amazing. Have a look at how many people have come here today to hear about the latest in MS research that's just been discussed at ECTRIMS 2025. You truly are part of a global MS community. We had a record number of people attend the conference, over 9,500 people at the conference itself. And as Bruno has already said, we have a record attendance for Patient Community Day. In no small part, that is to the work of the Spanish MS Society and all of the associated Spanish MS organisations, because I'm pleased to report we have over 1,000 registrations from Spain alone. So for our Spanish people in the audience, give yourselves a round of applause. That's an absolutely amazing turnout. Supporting partners, we have over 40 supporting partners this year that have come from 17 countries across 5 continents, really representing that this is now a truly global event. To make that particularly clear, I can also inform people that we have 3 registrations tuning in from Antarctica. So I hope they're all staying very warm while they're watching the broadcast. Considering we have so many people watching online who I'm sure would love to be in this room joining us in Barcelona, I was hoping that you would do something for me. I'm really hoping this works. Can we give our online audience a really warm Spanish welcome? If on the count of 3, can we all yell out as loud as we can and give them an hola, the one Spanish word that I can say? So in 3, 2, 1. I think we can do better. We can do better. Alvaro, you told me you would lead this.
Tiene que ser un poquito más alto, con más energía, ¿eh? Venga. 1, 2.
There we go. Perfect. And so, without further ado, let us get into the first topic. If we can just put the slides up in the room. So in this first session, we're going to be working through a patient's journey. We're going to be taking it through every step that I'm sure most people in this room really understand. And for most people, either here in the room or joining us online, that journey starts officially with being diagnosed with either MS, NMOSD, or MOGAD. However, we also know from listening to the stories of people in these communities that their personal journeys with these conditions started well before that time. Often, the diagnosis itself can almost be a relief from weeks, months, or even years of uncertainty. For neurologists and researchers, there has been a big emphasis on how this process can be improved, reflecting our enhanced understanding of these diseases and leading to quicker diagnosis and more effective treatments earlier. So I want to start the discussion with Gabriel and with Alvaro. We have new diagnostic criteria that have been talked about at the meeting. Can you share some of the insights with that with our audience?
Well, first of all, let me say how impressive it is to sit here and also see the turnout. It's really impressive, and thank you all for being here. And the answer is basically very easy. It's yes and yes. So we talk about faster diagnosis, but it's not only does have to be fast, it also has to be accurate, and ideally both. And the criteria from the AMS point of view will certainly do that to some degree. It's never perfect, but it will get considerably better. We will be faster. We will have a very much lower amount of people having to be in between, it may be, it may be not. We have to do it again in half a year or in a year, and they see what happens. It's never a comfortable situation, and there will be a considerable lower amount of people having to suffer from that because of the new criteria. And we are here at the birthplace of the new criteria, actually. So they were developed here 2 years ago, and it took some time, and it will take some time to disseminate it. Have all doctors apply them and have all the resources available. That will also take time, but we will get there. And that will be a lot of impactful, positive new things. And with accurate diagnosis, we have less misdiagnosis, and we have earlier and better treatment, and that's what we're aiming for.
Alvaro?
Thank you. Regarding neuromyelitis optica, the concept has evolved from the last century till now, and there have been many criteria trying to unify a concept. In 2004, they said this very big this discovery about the hallmark of the disease, antibodies against this aquaporin 4 channel, and this is like a inflection point in the history of this disease, since these patients having this antibody against this target who fulfill or who have central nervous system inflammation, they will have that disease. They will have neuromyelitis optica. So with this marker, we are able, and with we have been able to develop and go in deep into the physiopathology, and as a consequence, we have designed targeted therapies that have recently shown to have a great impact on reducing relapses. And we have now these drugs. We have now this hallmark for diagnosis. So we can start the treatment as soon as possible when this antibody is positive. But I don't want to forget the other part of the spectrum, which is the double seronegatives. As we have been discussing last year in the last days, there is a space to include those patients who have a syndrome, as the big disease suggested, like 1 century ago, and to gather those patients within the umbrella of NMOSD. And why is that so important? I think that this is very important because as we discovered the antibody in 2004, it's likely that in the next coming years, I hope, there will be other biomarkers that maybe will define another disease within the double seronegative NMOSD. Therefore, I think that it's important to keep this patient in mind. Yeah.
Thank you both. Often the next step after diagnosis for a lot of people, not all, is getting on to a disease-modifying therapy. And MS has been one of the most successful diseases of the modern era in terms of the development of these effective therapies. With over 20 available options, choices need to be made about what is the most appropriate for each person. But there is also constantly work being done to come up with more powerful options that are more targeted and have less side effects. At ECTRIMS 2025, we have discussed this at length, including personalised medicine, CAR T cells, HSCT, and potential remyelination agents. This theme also extends to other rare neurological conditions, where we are hoping to see a similar explosion in terms of the treatment options available. Bruno, I was hoping you might be able to start us off by talking about what some of these newer emerging therapies are in the MS space.
Thank you. So you have pointed the main direction in which new treatments are emerging. One of those directions is to target the inflammatory component of a disease in a different way, or even more accurately, especially to target when you have inflammation in the central nervous system, in the brain and in the spinal cord, but that the current treatment do not succeed to treat this inflammation on site. And so there are developments such as the Bruton tyrosine kinase inhibitor, who are not already approved, but are in active discussion about whether they should be approved and when, because they are reaching the CNS, the central nervous system, and they are able to reduce more or less this inflammation in the central nervous system, and they have demonstrated some benefit. So this is one possibility in one emerging therapies. You have mentioned other biotherapies. We will have new antibodies that target new mechanisms involved in the inflammation, and that may add to the existing one. And we have this new cell therapy-based treatment. You have mentioned the CAR T cell therapy. It's a very sophisticated cell therapy that is usually used in cancer or hematology, but that may be used to target the pathologic inflammatory cells involved in those diseases, because those diseases are inflammatory. So you have immune cells enter into the CNS, or that attack the CNS, or antibodies that attack the CNS. And by using cell therapy that is able to reach those cells on site and to kill them, we may achieve a big progress in the treatment. But this is really emerging, and there will be only a few patients and a few trials in this field. But they are coming, and we'll have many new results in the coming months and year. So this is one first part of the emerging therapy. The second is, let's say, to protect the brain and the spinal cord, or to enhance its repair or regeneration. And we heard about some progress. It's not, let's say, totally solved, of course, at this stage. But during this Congress, we had new information about the mechanisms of neuronal damage in the disease that may open the perspective of new treatments. We had new information about the mechanisms for repair and the demonstration that if you enhance the repair we call remyelination, so the generation of new myelin in the brain or in the spinal cord, we will also protect the neuron. It will be a neuroprotective strategy. And so we understand more and more those processes. And now moving to trials, I would note that at least 2 trials have been shown, one with a neuroprotectant agent that showed in patient with a progressive form of MS that you could, let's say, delay a little bit the progression by targeting some mechanisms in the neuron directly, so a neuroprotective mechanism. So this is, let's say, a first step. Here again, it's not yet approved, but it's a first clinical result that may call for further research or maybe further application in the clinical setting quite soon. And then we had also result about the remyelination trial. These studies are very hard to achieve. The fact that we had this result is already a very positive sign, because this is a hard study to develop, and it has been completed in a few years. So it was really nice to hear about this. And this study has combined 2 therapies that are known to enhance the remyelination in different models, and who had also shown preliminary results in small previous studies. And so this drug were clemastine and metformin. And the result is, let's say, positive, but not huge at this stage. So the combination of this therapy enhance a little bit the myelination, the remyelination in the optic pathway, but we have still to work about the long-term consequences of this enhanced repair in the visual pathway and in other places of the CNS. So this is a very positive sign, which call, let's say, new studies, and that will, I hope, and I'm sure it will happen, that will engage new program with larger studies, multi-center collaboration in this field, and this will be very positive for the whole field.
Thanks, Bruno. Darshi, can you give us the perspective from NMOSD MOGAD?
Thank you, and thank you for the invitation to be here on this great event. So when we're talking about treatment in NMOSD and MOGAD, I'll start with NMOSD, and Alvaro mentioned that this has been a disease that's evolved over the last decade and a half, and we know that when patients are acutely unwell with NMOSD or have an attack, we often use treatments like steroids and plasma exchange and so on to try and improve their outcome very quickly. What we do know about NMOSD is that patients need to be on a form of treatment to suppress the immune system for the long term. And there have been a large number of trials in the field of NMOSD over the last decade that have provided very good evidence for some of these treatments. These aquaporin 4 antibodies are the ones that are causing the disease, and they're produced by immune cells in the blood called lymphocytes or B cells. And so treatments that try and get rid of the B cells from the circulation or from the blood are really important. And certain trials have looked at agents that do that. One of these is called rituximab. One that gets rid of more B cells is called inebilizumab. So this is one type of treatment that have cleared, demonstrated in trials to be quite effective in reducing relapse rates. Other treatments that have been used in NMOSD target certain chemicals or molecules that are involved in inflammation. We call them IL-6 receptor MABs or interleukin-6 receptor antibodies. And these include treatments like satralizumab or tocilizumab. And these have also been demonstrated to be better than not having treatment in patients who have these aquaporin 4 antibodies. I think a very exciting type of treatment in NMOSD has been targeting what we know causes most of the damage in NMOSD, which is complement-mediated destruction, which is part of the immune system that is quite destructive. And we have these complement inhibitors, eculizumab, and then a treatment that can be given less frequently because it lasts for longer, called ravulizumab. And in NMOSD, there was presentations in this conference about the long-term follow-up, for example, from the ravulizumab trial, demonstrating that patients who stayed on that over a 4 or 5 year period continued to stay relapse-free. With all of these treatments, we know that we need to monitor for different potential complications and different infections. And so with these trials, we're learning how to deliver the treatments as safely as possible. Some interesting, very new types of treatment in NMOSD that have also been demonstrated over the years have been looking at stem cell transplantations or trying to tolerize or teach the body to deal with some of these conditions. And these are only emerging, and they're slow, and they've got few numbers of patients or participants in the study, and we need more follow-up, but these are interesting to think about. And Bruno mentioned CAR T therapy, which is certainly something that's being actively looked at in NMOSD, with some trials looking at this at the moment. So I think in the world of NMOSD, there's a lot of already identified evidence, and we know that with NMOSD, when you start treatment, you don't stop treatment and you continue to suppress the immune system because when you stop the treatment, the chance of relapses are higher. Moving over to MOGAD, this is a little bit trickier because I think to this point in time, we don't have trial, what we call class 1 evidence or really high evidence where we're looking at conditions and treatment response in a very controlled trial setting. What we do know from looking at cohorts or groups of patients from different parts of the world are that certain types of treatments seem to work well acutely. It's quite steroid responsive or prednisone responsive, but how long and how much we give and so on are still causes for ongoing research. And then there's been what do you do in the long term? We don't want to give patients steroids in the long term, so looking at treatments like intravenous immunoglobulin, looking at rituximab, which I spoke about earlier, that has some conflicting evidence from around the world, where some places say that it works and some studies show that it doesn't work quite as well as we'd like. So, this is still work in progress. Interestingly and excitingly, there are 2 studies that are currently looking at agents that change or try and reduce the recycling of these antibodies, rozanolixizumab, and a treatment, satralizumab, as well in MOGAD. And then there are a number of investigator-led trials looking at azathioprine and rituximab and steroid use. There have been case reports of stem cell transplant in a patient with very severe MOGAD. So I think the field of MOGAD is younger and maybe a bit less developed with the evidence from treatments, but hopefully the coming years can move that along quickly.
Exciting times ahead, and obviously a lot in development. Bruno, you're not quite off the hook yet on this topic. Ask a question from our online audience around the remyelination trials that are going on. Cheryl has asked, are these trials aimed more towards particular people, such as younger people, or those that are newly diagnosed? Can we just have a quick answer for Cheryl on that?
This is, of course, a very relevant question. Currently, those studies are what we call phase 2, so they are quite small studies that focus on patients who have already demyelination episodes in the optic nerves to measure the remyelination in the optic nerve. So they are quite focused for technical reason, but there is an active debate when to apply this strategy in the disease course. And ECTRIMS has organized a symposium on this topic 1 year ago, just to discuss about the design and the people who might be concerned. And we agreed that it might concern most of the patients, but for the investigation in the trial, we should probably at the first stage focus in some early stages of the disease, trying to protect early during the stage. But of course, also think about adding other stratified population, some with early stage and some with later stage, to have an idea about the, let's say, the real appropriate time where those treatment can be successful. So this is still an open question, which phase of the disease will be the more appropriate and will benefit more of this strategy. We still have to investigate this.
Perfect. Thank you, Bruno. As more and more treatments become available, MS nurses are playing a critical role, as their involvement in shared decision-making cannot be understated. And that's why at this year's ECTRIMS 2025, there was an MS Nurses session specifically on that topic. It's fantastic today to have 2 MS nurses on the panel with us, Amy and Joelle. And I was wondering at this time if you could talk to us about that session and how MS nurses are playing a role in helping people living with MS and people living with other neurological conditions navigate this time of their journey.
Well, thank you, Brett, and thank you to the organizers for the invitation to participate in this amazing event. We did have 2 MS Nurses sessions this year at ECTRIMS, as we have last year, and I'm increasingly excited about seeing nurses being included as part of the mainstream for ECTRIMS. This year, one of the major topics that we discussed was the concept of shared decision-making. Not only where the prescriber or the healthcare professional offers information or suggestions about what people should do or should take or should try, but to actually actively engage in conversation with the person with MS, with their families, their care partners, to come to a mutual decision about what is the best treatment for them. Now, I've come from an era where I started in multiple sclerosis before we had any treatment. And so I remember well the days that we had people and all I could offer them was support and kindness and hopefulness or optimism. And then came the explosion with our disease-modifying therapies, and this has continued over the years. That's only made my job much more difficult as a prescriber to help people make a decision about what's right for them. Very often people will say to me, well, what would you take if you had it? And I have to say, well, what I might take might be something very different than what you would take. So my message to our patient community is to actively engage in discussion with your healthcare providers. Be part of that shared decision-making. Joelle and I were talking earlier about the one presentation where one of our presenters developed a tool for shared decision-making. And as part of developing that tool, what they did was they surveyed hundreds of healthcare professionals and hundreds of people with MS, maybe some of you here in the audience today or in our virtual audience. And through statistics, they basically came up with the top 10 priorities for making a decision for the healthcare providers and the top 10 priorities for people living with MS. And when they compared those two top 10, guess what? There was not one thing that matched. And what that told me is that I, as a healthcare professional, I, as a nurse, need to do a much better job at listening to what people with MS are saying to me about what their needs and their expectations are in order to truly engage in shared decision-making.
So just to add to what Amy said, nurses also discussed the emergence of decision-making tools and decision-making aids for people living with MS. And also, these have evolved tremendously over the past few years since the onset of many new disease-modifying therapies. Our colleagues talked about how the original patient decision-making aids really included only few choices, like Amy was saying. Even some of them included the major the choice of no treatment. So, and this has become different and different as our people living with MS are dealing and looking at the overwhelming amount of disease-modifying therapies available now. And here comes the role of nurses and advanced practice providers to help you navigate these choices and make the proper informed decisions. These can be made through the evolution of decision-based decision tools, and also now with the emerging use of AI as well, and we discussed that in our sessions. How AI can really help, and we know everyone uses it, so we need to bring it into the conversation with our patients, and also advocate for better and safer use of AI as well, including the concepts of data privacy and how these might be affected by the use of AI in all of our patients.
Thanks so much, Amy and Joelle. So we've gone through, in terms of the journey, diagnosis, emerging treatments, and the role nurses play. But there has been a realization that beyond that point, people living with these neurological conditions want to be empowered to know what they can be doing on a daily basis to help manage their diseases. ECTRIMS 2025 has been a joint conference with RIMS, Rehabilitation in MS, with sessions covering topics such as mental health, exercise, aging, and cognition. Roshan, I know this is a topic that you are passionate about. Can you talk us through what's been discussed at the conference that I guess are particularly important for our audience who are looking for these sorts of strategies?
Thanks very much. It's great to be here in lovely Barcelona and here amidst all of you. It's great to be part of ECTRIMS, and every 3 years, as Brett said, we as an organization, RIMS, Rehabilitation in MS, get to really fly the flag for rehabilitation. Now, I know I'm kind of the last speaker here, but I'd like to flag that rehabilitation is not the end. It should really be right at the beginning also. You talked, Brett, about the journey of, that people with MS go through even before diagnosis. And I think rehabilitation should be part of that journey right from the start. So some of the topics we discussed in our sessions, this ECTRIMS, were around mental health. Now, mental health and psychological well-being is sometimes a taboo subject to talk about, and I think we need to get to grips with that and recognize that there are lots of people who experience difficulties with their mental health and psychological well-being. As clinicians, it's our role to help identify or pick up those issues, but I think as people living with MS and as family members of people living with MS, I think there's a role to be played about identifying what's happening with yourself. Sometimes it could be some things like worry or stress, which can kind of potentially get worse into anxiety. Sometimes it could be sadness and feeling upset that could progress to becoming depression. So the key thing is to kind of monitor and see where you're at and how you're feeling, because there are things that can be done. We've got very good, effective treatments, not just pharmacological treatments, not just drug treatments, but also psychological and psychosocial treatments that enable people to live better with dealing with anxiety and depression. So that's one thing I'd like to flag. And, it's more common than you'd think it is. So, it's something to be mindful of. The second topic I think I'd like to raise over here is around the use of digital technologies, and we've already heard about that. Yes, there are digital technologies all over the place, and it's unsurprising that that's also come into the world of rehabilitation. Now, when we talk about digital technologies, we could be talking about something very complicated, very fancy, robotics and all those kind of things. But we could also be talking about something that is potentially available to most people in your pockets, in your purses, potentially your mobile phones. So that's also a digital technology. And we're using these digital technologies to help identify problems. So that's one way in which we can try and use some of these technologies. We can also use these technologies to provide treatments or rehabilitation remotely. We know that not everybody who needs rehabilitation gets it. And let's face it, a lot of our healthcare systems are stretched. We don't have enough resources. So digital technologies can play a role to democratize or to provide more treatment for more people, particularly those living further away from specialist rehabilitation centers, where such specialist rehabilitation centers exist. So rehabilitation through remote ways is a possibility. And the third way in which we use digital technologies is to monitor the effect or potential effect of rehabilitation also. And this is something that you can do yourself. Now we've got things like Fitbits and all these apps on our phones, which are pretty ubiquitous. And, sometimes you could use those as a mechanism to kind of measure how you're doing yourself. Some people are more interested in creating a challenge and meeting that challenge. It doesn't work for everybody, but talking about that, it's also important to highlight that when we start thinking about digital technologies, we also need to think about who we are potentially excluding. And that's something we need to be mindful of. So amongst clinicians, we're very aware of that. So it can be one solution, but it should not be the only solution. And the third thing I think that we wanted to highlight from our sessions over the course of the last few days is around aging and rehabilitation and aging with MS. We're all aging. Some of the problems that emerge or the symptoms that emerge with MS kind of mimic what happens to our aging bodies also. And what happens as we age and we have MS, we need to be thinking about that. Now, these are not easy topics to disentangle, but some of the solutions that we've got from a rehabilitation side, from a rehabilitation angle, can be applied for both aging and for MS.
Thanks, Roshan. And actually, some of the topics you brought up there ties in with a pre-submitted question that we had, mental health being a big one. And the question was around when people living with neurological conditions talk about experiencing mental health concerns, sexual dysfunction came up as well. They don't quite know how to start these conversations. They don't know how to bring up these topics with their healthcare professionals. Do you have any insights in terms of how to navigate those? And as a word, I'm going to be going after this to the nurses because I think they'll also be able to give us some insights on this.
Absolutely. And I'm glad you brought up shared decision making. So I recognize fully well in very busy clinics, it's not always possible to bring up everything you'd like to as a clinician yourself. So here's a challenge for those of you with a neurological condition to actually also think about what it is that you want to discuss. And, you know, we know that sometimes thinking about or remembering what you'd like to discuss can also be a challenge. So one advice that we often provide suggest to people with MS and other neurological conditions is to actually jot down some of these issues and then bring them to your clinician. The other thing we've been able to do, talking about digital technologies again, in some of our centers, we actually send in advance some information to our patients to say, do you have concerns with any of these issues, particularly the invisible symptoms, which can be quite difficult to talk about. So that might prompt you to say, oh yes, I would like to talk about this. And in a way, it opens a dialogue that can be picked up then during the consultation.
Perfect. So just before we go to, we're about to have some time for questions from the audience. So start to think of your questions that you would like to ask our panel now. We just want to ask with the questions. We can't answer any personal medical questions. So we ask that you restrict your questions to questions about research. So start to think of those. Before we get to that Q&A, Amy and Joelle, I think clearly nurses are playing a role in the discussions that Roshan was just talking about. And one of the topics, again, that you had at the conference this year was about how people living with neurological conditions can become activated. Can you talk about that and the role that you play in that?
Definitely, yeah. So nurses and colleagues of ours have really worked on increasing patient engagement and patient activation, which is an active, really, rather than a passive involvement in your care specifically. One of the really interesting research ideas that have been done by our colleagues is the creation of a patient expert program, whereby instead of using regular support groups where the discussion might sometimes not always be completely geared towards expert advice, creation of an expert patient program really helps because it puts at the center of that support group or discussion an expert patient created and assisted by nurses as well, where the clinical nurse is really observing what is occurring. And this has really showed improvement in mental health, in quality of life, and in adherence to treatment. So this is where patients will sit together, led by an expert patient identified through research methods, of course, and they will come together answering each other's questions, giving advice, and causing a real change in commitment to therapies or even lifestyle modifications.
Yes, our presentation had Miguel Robles from here, excuse me, in Barcelona, who actually, as part of his PhD dissertation, developed the concept of the expert patient. And we also had one of his expert patients as a speaker who taught those of us in the nursing audience a tremendous amount about what it's like to be an expert patient. And I think the only thing that I would add to all of this is to remind people with MS and NMOSD and MOGAD not to forget about the little things. Don't get all enthralled or engrossed in the big issues and the big data and the big bits of information perhaps that have come from this meeting, but take it back a step and think about the smaller issues. Think about the things that matter to you. And maybe really for the last 3 weeks or 6 weeks, what's mattered to you is your bladder. And that's the thing that you need to engage your healthcare provider with. We, like you, will often send out a one-page questionnaire asking people about what their priorities are, what things have perhaps been an issue for them in the last couple of months or since the last visit. And we try to focus on those.
Okay, thank you very much. I'd now like to throw over to the audience to ask any questions that you might have for our panel. If you raise your hand, we have people with microphones coming around, and we do have Alvaro on the panel, so if you do want to ask your question in Spanish, he's assured me that he will translate it for us. Questions? One over here.
¿Me tengo que presentar o algo o no? Solamente lanzar la pregunta. Buenas tardes a todos.
You can continue. Good afternoon to everyone, and I will translate later if you want. Si quieres continúa, perdona, y luego haz la pregunta y ya luego traduzco. Gracias.
Vale, muchas gracias a todos. Mi pregunta es la siguiente. Con el paso de los años se ha demostrado que la inflamación de los pacientes con esclerosis múltiple va reduciendo, pero a la vez el deterioro cognitivo va aumentando. Entonces, ¿qué estudios o qué experiencia tienen ustedes con el paso de los años la evolución de la esclerosis múltiple?
Gracias, gracias. No, the question is about related to MS. So, ¿cuál es tu nombre? Perdona. ¿Cuál es tu nombre?
Mi nombre es Pilar Gallego.
Pilar.
Soy presidenta de ADEMTO, en Toledo.
Vale, muchas gracias. So Pilar is saying that along with the time, the inflammatory stages of the MS is decreasing, while the cognitive impairment is increasing. And she just wanted to know if si lo he entendido bien, si hay estudios que relacionan la inflamación con el deterioro cognitivo, ¿puede ser?
Del deterioro cognitivo. O sea, son dos cosas distintas
Sí, sí.
que al final se emergen en esclerosis múltiple. Entonces, como los estudios cada vez avanzan más, pues yo quiero saber si ese tipo de estudios o ese tipo de evidencias están demostrados.
Okay. So she wants to know if there is a link if there are studies that have shown that with time there is a decrease of inflammation and a decrease, and an increase of the cognitive impairment.
Bruno. Gabriel.
Thank you. I think I will reply in English because in Spanish I would be less capable. I think it's an important and interesting question, and we had some presentations on this topic here. And you're right, the cognitive changes that you can experience in MS, which are usually existing, not always, but sometimes, and may evolve during the disease courses. They are not affecting all cognitive capacities. They are affecting the speed to deal with information, so the concentration, the attentional capacities, and some memory capacities. They are starting at a certain point, but they are partly independent of the inflammatory activity of the disease. This is quite well shown. So it's not a relapse to have a cognitive disorder, even if a relapse can enhance a little bit those disorders. Having a cognitive disorders is a consequence of several mechanisms that will join to limit the cognitive capacities. And those are linked to what we call, probably, because we do not know exactly what is behind, but the neurodegenerative, or the progressive part of the disease, because this the fact that neurons are working less well explain part of those cognitive disorders. This is clearly one thing. The second is that it's not one neuron who is making a cognitive function, but it's a connectivity, the organization in a very complex network of different neuronal systems. So hundreds of millions or billions of neurons. So what we call networks. And those networks are able to cope with the lesions, with the damage of the brain, up to a certain level. And after a certain level, you have cognitive disorders that appear as a consequence of this damage that may evolve with time, independently of the inflammatory activity. And the third point is also what we call the cognitive reserve, and probably our colleague might be able to talk about this also. But what you call the cognitive reserve is the fact that you have acquired during your life, during infancy, during early days, but even after, due to training, due to leisure, you have acquired some capacity that your central nervous system is able to face to this damage. And if you have a good cognitive reserve, you can face more damage than if you have less cognitive reserve. So it's always a good perspective to train this cognitive reserve, probably as soon as the disease starts, or even before, if we know. But because this is one of the important components that may limit the cognitive disorders. So all those processes are partly independent of relapses, acute relapses, and acute inflammation. This is why those cognitive disorders are only partly, but partly independent of inflammation. So this was really a profound, deep question, very important question.
Thank you very much. Thanks, Bruno. We will also have a focus on cognition in our second session, so you'll get even more information on that. And we have time for one more question from our live audience. We will also have time during our networking session, which is coming up in the middle of the day, to also ask more questions to people in the room.
Thank you. This is Agustin Fons from the Spanish Association of NMO and MOGAD. Thank you for the warm welcome this afternoon. Some of you have talked about the importance of keeping a log of what's happening to you. So that may be a help for the practitioners. Now, maybe I can ask to my Spanish doctor present in the panel. So who should provide us of this example of a log, or should we try to make it ourselves? You're going to help us to provide us one. Should we maybe copy what the Goethe Jackson Foundation has done with their patients? How can we improve our situation with the log, and who can help us to produce that log?
¿Me lo puedes decir en español? ¿The log?
El log es como un blog de notas donde pones los que te pasa, ¿no? Entonces, hay ejemplos de, claro, hay que tener campos que hay que rellenar. Pues los campos los fabricamos nosotros, nos los proveéis vosotros, o queréis que copiemos algunos que ya están hechos.
Los campos de...
Que hay que contestar para explicar lo que te pasa durante los días entre visita y visita.
Yeah. I think this is a good and very important question. I think that sometimes patients feel that doctors are worried about some symptoms that they are not that the patient feel that is not the most important thing. I mean, for example, I think that patients sometimes feel that doctors are focused only on which is the extension of the myelitis. Do you have motor problems? Do you have a fatigue? But there are few, as you have said, small points, small things, like you feel that every single patient feel in your personal life that have doubts because you don't know if it's derived from the disease or if it's independent of the disease. I think it's quite difficult because we can get obsessed if we focus too much on what is going on to ourselves as a patient, no? But I think that maybe why not to write in notes and then I like when the patient come and take out the note and say, doctor, I have a list of things to tell you, and say, okay, come on, start. You know, I think that this is important because you are not gonna forget anything. You are gonna focus on the things that matters to you. And we are here to try to respond and to answer all these questions. So I think it's very important to go to the doctor with notes in order to forget what are your worries.
Well, in the interest of time, we are going to have to wrap up session 1 there. So can I have everyone in the room thank all of the members of our amazing panel from session 1 for sharing their insights.